Good evening, everyone. Welcome, and thank you for registering for our webinar this evening, which is entitled Understanding, well, sorry, let me back up and sort of say it's a part one of a three-part series, Understanding Type 1 Diabetes Risk Detection and the Emotional Impact. And it's important that we acknowledge that this has been made possible by an unrestricted educational grant from Sanofi Canada. My name is Lori Berard. I'm a nurse and I work as a consultant in diabetes and clinical research. I'm based in Winnipeg, and I'll be your host and discussion facilitator for today. This is the first of a three-part webinar featuring healthcare professionals discussing risk, detection, and the emotional impact of type 1 diabetes. So a couple of housekeeping details. Please submit your questions in the chat box or the Q&A throughout the webinar. We're going to answer as many as we possibly can in the final 10 minutes of our time together tonight. We're anticipating that the webinar this evening will be about 20 minutes of content and then about 10 minutes of Q&A at the end. For your information, so that you don't have to madly write things down, all of our webinars will be recorded and available at Diabetes Care Community website for future viewing. And finally, important, we'd like to hear from you, so there will be a short evaluation sent to you at the end of the webinar. Okay, so let's get started. If I could have the next slide, please. So I've already introduced myself as Lori Berard, and I'm delighted to be here. I have a little bit of an interest in this area. I've been in diabetes for a very long time, and I worked on some of the screening and interventions in terms of the prevention of the progression of type 1 diabetes in the past. So it's a bit near and dear to my heart. And I'm joined today by Dr. Anna Lamb, who's a staff physician in the Division of Endocrinology and Metabolism, and an associate professor at the University of Alberta. And she's a member of the University of Alberta islet transplant program, which is a huge program, very well known worldwide. And her personal research focuses on understanding beta cell function in type 1 diabetes and islet transplantation. So welcome, Dr. Lamb. Thanks for being here this evening. Maybe we could get you to take us through the next slide.
Thanks, Lori. All right, so for the agenda today, hopefully by the end, you'll feel comfortable with or have a better understanding of the role genetics do and do not play in type 1 diabetes, how the autoimmune process leads to type 1 diabetes, what autoantibody patterns can reveal about risk, and the early signs that families and parents should be aware of.
Okay, great. So we're going to just have a little bit of a conversation, you and I. This is where we're going to sort of really understand your expertise in this area. So let's talk a little bit about the concept of genetics and risk. So really, how much does family history really matter in type 1 diabetes? Like, if no one in the family has type 1 diabetes, can it still happen?
Yeah, so we know that family history is an important risk factor. So if someone in your family, like a parent or a sibling, has type 1 diabetes, that increases your risk for developing type 1 diabetes by 15 times. So it's an important risk factor, but it's not a guarantee. And that makes sense, right? Because within those families, not everyone has type 1 diabetes. And so there are other factors that come into play. And actually, a surprising stat for people is that the majority of people with type 1 diabetes don't have a family history. So more than 85% of people who have type 1 diabetes don't have a family history. Other factors aside from that family or genetic risk is environmental factors. So many different things in the environment. So it's hard for us to pinpoint exactly what those environmental triggers might be. Like an example would be a viral infection that might precede and activate the immune system and set off people for increased risk. But it's the interplay between genetics and environment.
Great. So just a quick question before we move on to the sort of talking a little bit more about the concept of autoimmunity is like, what about twins? So,
Yeah.
if you have, did both twins get it? They have type 1 diabetes?
So, there is a strong concordance, but it only accounts for 50%. So if you have a twin that has type 1 diabetes, a 50-50 chance of having it or not. And that really speaks to the fact that there's other factors
Other
aside.
things, yeah.
Yeah, exactly right.
Because when we think about it, if it's really genetic, they supposedly have the same genes, but
Exactly.
there's obviously something else that has to happen with that. Okay, so let's move on and talk a little bit about the concept of understanding type 1 diabetes as an autoimmune disease. What does that mean to our listeners today?
Okay, so when I think about diabetes, and I think most people do, we think about it as a problem of handling glucose or blood sugars, high blood sugars. But when we're looking at type 1 diabetes, those high blood sugars really are the result of an autoimmune process. Type 1 diabetes is an autoimmune condition whereby the immune system inappropriately recognizes and targets the pancreas insulin producing cells as other. And those insulin producing cells we refer to as beta cells. And that process, that autoimmune process occurs years ahead of when we see patients in clinic, when they have symptoms of high sugars, when their lab values show that they have high sugars. That's kind of counter to how we understand type 1 diabetes. Oftentimes, patients are diagnosed, they get really sick, they have a sudden onset of symptoms and can present in an emergency. And it seems like diabetes developed overnight. But in fact, that autoimmune process has been going on for years ahead of when people are presenting with type 1 and getting diagnosed.
So a little bit about that is that, you said it's over time and we're starting to hear buzzes about stage 1 and stage 2. Can you help us understand a little bit about what that actually means in terms of this unfolding over time in these stages?
Yeah, so the stages really allows us to think about and monitor and potentially treat diabetes as an autoimmune condition. So we're not focused solely on the glucose part, but we're looking at the autoimmune part. So type 1 diabetes occurs in 3 stages. The first stage is where you start to have that autoimmune attack on those beta cells, those insulin producing cells. But you still have enough beta cells to make enough insulin to control glucose levels and handle glucose. And so at that stage, you are asymptomatic, or patients are asymptomatic and their sugars are normal. And over time, as that immune attack on those beta cells is progressing, you lose more beta cells. And so that ability to manage glucose is less. And so you progress into stage 2. That means you start to see creep up in glucose levels, but not to the point where you would feel it in terms of symptoms or that you would meet the diagnosis for type 1 diabetes. Finally, in stage 3, that's what we know as clinical diabetes, and that's where we meet patients in clinic or hospital and they get diagnosed. You've lost a critical mass of beta cells, so that the body can't safely handle glucose. We're seeing glucose levels in the range, the diabetic range, potentially higher in kind of medical emergency diabetic ketoacidosis, DKA range.
Okay. So this is all, again, this is evolving. I mentioned earlier, I've been in diabetes a long time. So we didn't know about this even 5 years ago, really. You probably did as a researcher, but the rest of us didn't really know anything about staging. So how do we know this is happening before the symptoms appear?
So we can actually do blood tests and measure antibodies. The antibodies are markers that there is something or there's an immune attack on those beta cells that's occurring. And there's 4 antibodies that we can measure and screen for. And those antibodies developed soon after that the immune system's activated and you get those beta cells under attack. And that means that we can detect the disease process early before people are presenting. So identify people at risk earlier than when they're diagnosed with type 1 diabetes.
And if you have antibodies, does that mean that you're definitively going to go on and develop diabetes?
So it depends, right? So of the 4 autoantibodies, the more you have, the higher the risk you have. So if you have 0 antibodies that are positive, minimal risk. If you have 1, maybe increased risk, but not as much as if you had 2 or more autoantibodies. When you have 2 or more autoantibodies, the lifetime risk is near 100%. So if you have 2 or more antibodies and it's confirmed somewhere in your lifespan, we can confidently say you will develop type 1 diabetes. So those antibodies, when you have 2 or more, identify that risk, but it just doesn't tell us exactly when it will develop. But it gives us time to intervene and potentially prepare patients better for that diagnosis.
So it's really about prevention, right? So
Yeah.
preparedness means also prevention. Prevention of, you mentioned diabetic ketoacidosis and hospitalization. So knowing this and being aware can be very helpful. So, sorry, and I kind of started to answer this with you a little bit, but like thinking about people affected and their families, like why would you want to be screened and know this information? Why, how does that help them?
Yeah, I mean, I think can be viewed as a double-edged sword because you're like, I'm getting
Mhm.
these antibodies and you can't tell me when I'm going to be diagnosed. And do I really want to
Yeah.
know that? But on the other hand, as you said, it's like information and education is empowerment. And so, if we are able to help patients and their family understand what it looks like, what the signs and symptoms are for type 1 diabetes, so that they can monitor and seek medical care earlier than they would otherwise, and avoid them presenting in that medical emergency and the surprise situation. The diagnosis of type 1 diabetes, when it's sudden and abrupt, patients can be really sick. It could be a medical emergency, and if we can avoid that stress or trauma, that looks like, aside from recognizing symptoms, but having the supports in place, knowing what to anticipate, what insulin therapy looks like, just kind of easing that transition into diagnosis. The other part of it is also that we might be able to offer immune therapies. We're limited right now, but as we develop that area, we might help. Screening might help people get into treatment and delay progression that way too.
And I think, Dr. Lam, it's really changed a lot. So this conversation that you and I are having about looking for antibodies and being aware and predicting. So not only, and you briefly mentioned, and we will get into a bit more of this conversation in our next webinar, but now that we have so much more information about what the antibodies do, what they actually mean, what the stages are, and we have potential intervention, it's a very different conversation than we would have even been having 5 years ago, you and I. We might not have had all of this background information. We still had antibody screening, and we mostly used that in people to figure out whether they actually were type 1 diabetes or type 2 diabetes. But now people who are considered at risk of developing diabetes can have it done so that they can be more safely monitored, that we can prevent these medical emergencies. And as you said, maybe there will be some potential for emerging therapies that will be possible. And that world just continues to expand. You and I could have a conversation a year from now and it could be very different than today.
Yeah, it's.
Good.
I just
Go
want to say
ahead,
it's a
sorry.
really exciting time, and you're right. When you said that probably 5 years ago, I knew about this stuff. I didn't, right? And so it's just as like this, like always out down the pipeline, we were going to find something that would change the disease course, and we're there now. Like it's
Yeah.
not exactly what we want, but we're close and we're making progress.
And I think that that's why it's really important for us to do sessions like this to help individuals to really start to understand why these conversations are occurring. Because, we've been quiet about this because it was all science, it was all
Yeah.
research. It didn't really change the course for people
Hmm.
so much. But now we've learned and we have all this evidence that's been created through great scientific work like you guys have done at the University of Alberta. And so we've had this opportunity now to step forward and say, hey, listen, this is what we know and this is the why. So why don't we just sort of finish this up by saying, okay, if someone has been screened, what messages are you giving to the family in terms of the signs and symptoms that they should be watching for? Because I think that that's really important. Antibody knowledge is one thing, but when do they start to think about, seeking more intervention?
Right. So if someone's screened positive for these autoantibodies, the signs and symptoms to look for that would indicate that glucose levels are rising. The classic symptoms would be extreme fatigue that's unexplained by kind of activity, weight loss that's unexplained as well. And usually that's associated with increased appetite, increased intake, but they're just losing weight. Excessive thirst, excessive peeing, wetting the bed, for example, when they hadn't done that before, peeing overnight. Sometimes vision changes as well. So that constellation of symptoms, if they occur alone or together, not always indicating high sugars or diabetes, but certainly in someone who's high risk, that should prompt seeking some kind of medical attention, blood work, checking glucose levels.
Okay, great. So that's kind of the messaging that we wanted to. So if before we open this up to, and we are starting to get some questions, so I'm really excited to get to that. What, because that's what's important, right? Is for people to be able to pick your brain. What would your key takeaway messages be for people listening today?
So one is that family and genetic risk matters, but it doesn't guarantee it, right? And so we have a large proportion of patients who have type 1 diabetes that don't have the family history. That type 1 diabetes is an autoimmune condition. It's not just a disorder of glucose metabolism. And that means that we can actually screen and test for it earlier than patients developed that high glucose level, and that we have screening options in Canada as well.
Okay, excellent. So I have a few questions here that I'd like to get through in the next 10 minutes that we have together. So let's just start with this one. And I actually was gonna, okay, I actually was gonna kind of ask this question too of you, but sometimes type 1 diabetes is diagnosed much later in life. And so how do you make the distinction between type 1 and type 2?
Yeah, that's a tough question, and I think it's a question that's going to come up more and more. Right? So we used to think of type 1 diabetes as a diabetes of childhood, but we now know that more than 50% of people are going to actually be diagnosed in adulthood. We just kind of miss it because type 2 diabetes is so prevalent. What makes it more challenging to tease out in later life is because patients might not necessarily meet the characteristics that we identify or associate with type 2 diabetes necessarily, versus type 1. And so if someone doesn't exactly fit the type 2 picture where we're needing insulin right away, or maybe they have a leaner body type, or they're more insulin sensitive, it just is when people don't exactly fit that picture that we start to think about type 1. The other things are like family history of type 1 diabetes or autoimmune conditions, like personally as well, that would make us start to think. But it's just a matter of this doesn't exactly look like type 2 that would tweak
Yeah.
like my spidey senses.
And I think what I was thinking about while you were giving us some of the information earlier is that the onset, you talked a little bit about onset and how it
Mhm.
can be fine today and gone to, it's very sick tomorrow. And my experience often has been is that when people are diagnosed with type 1 diabetes later in life, that it tends to take a little bit longer when you're 40 years old than it does when you're 4 years old. And so, they're fine today and crying and peeing and drinking like crazy at 4, but you're 40 and you're kind of like, what do you mean you have ketones on diagnosis? Like it's
Yes.
because we typically not, we sort of are always thinking that it should be type 2 diabetes based on age, but when we look back, it's been slower progressing type 1
Yes.
diabetes. But that's enough about me because
No,
I have lots of questions for you here.
I want to add to that because I didn't get to that nuance, but it's actually we are understanding that children who are diagnosed like younger onset type 1 diabetes versus adult type 1 diabetes, it progresses differently, right? So the younger you start with it, the quicker to progress, like the younger to have those
Yep.
autoantibodies, to have that immunity. And what that means is that you may have more time to intervene for adults. It also means that we might be more intensive in that kind of monitoring for children compared to adults. So it does have important implications.
Okay, so the very quick question is what are the four antibodies?
So there is an insulin antibody, there is an anti-GAD antibody, anti-insulin antigen antibody, anti-zinc transferrin 8 antibody. Um, and sometimes historically they've been referred to different things, and sometimes different antibodies are important in like children versus adults, like anti-GAD, more so we see in adults versus
Mhm.
anti-insulin. Um, and it seemed like the type of antibody you have might change your risk as well. But that's a really rapidly evolving field that I wouldn't want to hang my hat on. But number
Mhm.
of antibodies, type of antibodies might explain some of your risk for progression too.
Okay, and another sort of, I'm just going to lump a bunch of questions together, but
Mhm.
there's people who've asked about children, they've asked about ages, about new siblings to a child already diagnosed with type 1 diabetes, but basically, oh, and half siblings. So, who should be screened based on their family history? So, what would be the recommendation for type 1 screening?
Yeah, so if you have it in your family and certainly in a first degree relative or a family history of type 1 diabetes, I think it's reasonable to screen for it. And I think that comes up in the next webinar, but TrialNet is a research program that supports the screening in people who have family history of type 1 diabetes. But certainly, if you have a personal history of autoimmunity, so that's like celiac disease, rheumatoid arthritis, hypothyroidism in your family or yourself, that would be another, I think, indicator to test. And again, also, if you fit into that, like my diabetes doesn't exactly fit type 2, like doctors are giving me confusing information or I've needed insulin right away. That would be another scenario to screen for those antibodies, kind of like what you said historically with those autoantibodies.
I'm just gonna, so I just want to reiterate that you've answered the question about other autoimmune diseases in an individual or in their family, so they should be screened.
Yeah,
And then the sibling issue, one of the questions was, half sibling. So you wouldn't just say, well, you're only a half sibling, so your risk is not there. You're still a
yeah,
sibling, and we don't know which parent it came from.
yeah,
So yes, you should be screened. Okay.
agreed.
Sorry, you have triggered like a gazillion questions here, so I'm just trying to monitor both the chat and the questions as well. How old should a child be screened at?
Well, I think that's a evolving question too, because we're not sure exactly which windows patients are should be screened. But I think 2 to 6, somewhere in there, would be a window to test, and potentially later on as well if it's negative in
Yeah.
that window. Yeah,
And you and I are but not from we're not from the same province. You're from Alberta. I live in
yeah,
Manitoba. And right now we do know that general screening as a screening versus a diagnostic
yeah,
antibodies, because you in different provinces you can get different antibiotics if you're trying to antibodies if you're trying to figure out
yeah,
whether someone has type 1 or type 2 diabetes, but you can't necessarily order them
yeah.
and have them covered by the provincial governments. So that was one of the questions. And I think, as you said, in our next webinar, we're going to talk about how people could get screened, but we don't believe that anywhere across the country that general screening is covered by the provincial plans.
Yeah, we're not set up for it, but there is a pilot grant that's looking at that, like acceptability of general screening, because oftentimes we're thinking about targeted family risk or that autoimmune risk, but
Mm-hmm.
85% of people don't have family history. So we really
Mm-hmm.
need to broaden that screening, um, and also not do it piecemeal. Like we can do it at individual centers, do 1 or 2 antibodies, but we really need that full panel across the board. But there isn't a program as of yet. Yeah.
A quick question about, and I think that there's just been some comments in both the chat box as well as in the questions, is like things that could lead to diabetes. So one is about trauma, so whether that's like emotional trauma or physical trauma, pre-diabetes or shingles, and then there's also a question about, is there medications that can tip you over? So when you think about, I think if I could put this into just sort of a nice little package for you, it'd be, we know that type 1 diabetes is genetic, and it's autoimmune. And what can trigger the autoimmune response, I think might answer some of these questions.
Yeah, that's the $1 million question, right? Because like genetics is important, but environmental factors is, and there's been a lot of work to try to, identify the things that we can target in on in the environment. But it's hard to study things in the environment because there's so many things that we can't control for. But some things like infections have come up, and particularly in children, like viral gastrointestinal infections seem to precede the development of type 1 diabetes in some children. There's a question about like early milk exposure, for example, and the calories in a diet and overnutrition may be another risk that that metabolic stress can maybe stress the beta cells and start the immune system off. Vitamin D deficiency maybe has been implicated, gut microbiome, a lot of things that people are exploring, but nothing so far that we can pinpoint and say these are the things you should be doing in terms of environmental exposures or lifestyle changes.
I have two questions I want to lump together for you here. So, a husband and wife both have type 1 diabetes as adults. What should they tell their children about risk? And is there ever, this is the second part, is there ever an upper age limit to say your parents have type 1 diabetes, you're now 40, don't bother getting tested? Is there ever an upper age limit? Or now that we may be doing this more broadly, if you have a parent with type 1 diabetes, regardless of your age, you should be tested. So what would you tell your child if you have two parents? And is there an upper age limit that you'd say you're
Yeah,
probably okay?
the first one I think is easier and I'll take that one first. And
Okay.
you would tell your child that you have an increased risk. And I don't have the firm stats, but I think that for mothers, the risk is 4% risk and 8% for fathers. So it's interesting that like different, depending on who in the family has it, the
Yep.
risk can be different. But I don't know what that means for both parents to have it, but I would just assume that that is increased further. So I would certainly encourage them to get tested, is that they're at increased risk and they should get tested. And there isn't a cap on when that diabetes can occur. So I've seen patients who are diagnosed in their 60s, for example, 40s. And so I don't think we have a clear optimal window for testing. And so if that risk is high, I probably would consider testing later on, or certainly be mindful of those symptoms, signs and symptoms of high glucose that they should be mindful of as well.
There was a comment about a child diagnosed at age 3. And then the question would be, has the autoimmune response been there since birth, since it's been going on for years? Would antibody testing be recommended? But I think what we're sort of saying is the genetic risk and the there, it's kind of there. It's the like how would you like to answer that, Dr. Lamb? I'll leave that to you, but it's kind of this idea about, okay, if we did maybe birth related screening, does that change? And we're not there yet by any stretch of the imaginations,
Mhm.
but the younger that they are, it's autoimmune response has been there since birth, since it's been going on for years. Would antibody tested be recommended in
So
earlier? It's kind of a tough question. Sorry.
yeah, I mean, I think in someone who has been diagnosed and has type 1, then the merit of testing at this time is not clearly there. But in terms of like,
Hmm.
if we were able to screen and we had general screening ahead of time, we probably would have been able to mitigate or like
Yeah.
change the presentation. So there would have been merit in that. But the windows at which you're going to be screening maybe
Yeah.
6 months to a year, for example. Yeah.
Okay. Can I just ask you one last really quick question because we're almost at time? So, and it kind of comes to the last question. Sorry, I'm reading and trying to,
Yeah, I know
appease
you're
our
doing.
audience with as many questions as I can and trying not to ask you like a whole bunch of individual ones. But I think so the comment is that there's four different ones. And then there's a question from someone who's like, I have one, and someone else who's like, I was diagnosed as type 1 LADA. Should I be asking for these? But I guess it's like, so antibodies, do you go from having one to two to three to four? And I would suggest that if you know you have one, that you should be on a trajectory for, understanding when you might seek more care. But what about the numbers? So that's kind of the last takeaway is that there are four that you could be tested for. If you have one, does it progress to two? Does it progress to three?
Yeah.
Or what does that look like?
I can't give you hard numbers, but certainly having one is a lot different than having two or more, right? So,
Hmm.
just for antibody testing, we can have false positives, right? So that one positivity can come and go. But
Okay.
if you've gone on to have that testing because you have an increased risk, then there's probably a merit in terms of testing those autoantibodies again, but at longer lengths of time, at
Okay.
intervals, right? But if you have two or more autoantibodies, that's really when the risk is 100% certain, right?
Okay.
Autoantibodies are not perfect tests, but once you've had those measured and they're confirmation we haven't really talked about, but once they've been confirmed, then we would call that stage one diabetes. Yeah.
So basically, if you've done the screening once and you already have one, you should have a plan for future screening. If you've done the screening and you have two, then you definitively should be having a plan because
Yes.
you're stage one. And if you have recently been diagnosed and you're unclear, you may have actually been done clinically, and you might ask that question
Yeah.
of your provider, if you're especially the person who was type 1.5 or LADA, like that might be a
Yeah.
question because maybe the provider's already doing that and it's going to bring the information.
Yeah.
Dr. Lamb, thank you. That was amazing. There was just there were so many great comments coming in and so many thank yous to you for this amazing presentation and the information shared. And for those of you that have questions around TrialNet or what the government's going to do or what we're going to do for the next steps, you can join us tomorrow when we have part two of this webinar going on into sort of what's next. And I would just like to, again, thank everybody for attending today, and a special thank you to our presenter, to our hosts, and again to Sanofi for making this possible. And please, please, please fill out the evaluations that are going to be sent to you. Obviously, we had a lot of people joining with a lot of great questions, and we really want to make sure that we continue to meet your needs. With that, everyone, I'll say thank you. Enjoy the rest of your evening, and go Canada, go in the Olympics. Take care.
Have a good night. Thank you.